Greetings, everyone. I'll be presenting today on pituitary disorders in pregnancy. It is not commonly encountered during our day to day practice, but it's important for us to know a few related and important conditions when we do actually encounter them. The learning objectives for today would be understanding the anatomy and physiology of the pituitary gland, management of pregnant women and prolactinomas, what is pituitary apoplexy, pituitary dysfunction and hypothyroidism, and Sheehan syndrome. I'll start off with a case presentation. We have Madam NZ, a gravida 2 para 0 plus 1 at 24 weeks, with an underlying pituitary macroadenoma, which was diagnosed in November 2019. Then, the MRI showed a pituitary tumor measuring 1 by 1.6 by 1.2 centimeters, which was a non-enhancing lesion. It abuts the optic chiasm, but there was no evidence of any mass effect. She was then diagnosed with a non-functioning pituitary macroadenoma. The endocrine team input at that point after assessing the patient was that she did not require any medical treatment. The optal input, there was no visual field defects, and neurosurgeons felt that there was no indication for a surgical intervention and was for an expectant management. However, she presented a year later, and this time she was pregnant at 20 weeks. She visited to the hospital twice complaining of headache. However, she was given a review a month later. At 24 weeks, there was a blurred vision of both eyes, left more than right, of 1 month duration. She also was still having the persistent headache. Ophthalmic examination showed bilateral eye superior temporal visual field defects, otherwise the rest were normal. Blood investigation showed a raised prolactin levels at 24 weeks, almost double from the pre-pregnancy levels. Of course, as we know, prolactin levels can be raised during pregnancy. The MRI this time showed a pituitary gland with an increased size of almost double 1.8 by 1.3 by 2.1 centimeters, with a layering with blood component at the dependent aspect of the lesion, a widened cella turcica, and the lesion compressing the optic chiasm. The impression was a pituitary apoplexy with local compression of the optic chiasm. As you can see, that there is an echogenic and very white-looking lesion within the pituitary gland, and this shows an hemorrhage, which actually shows an hemorrhage, which is the pituitary apoplexy, which I'll explain in my subsequent slides. So an MDT was done. The neurosurgical, endocrine, and the MFM team felt the best way for the patient is for a surgical intervention in view of the increasing size of tumor. Surgeons took a right supraorbital craniotomy approach, and the tumor was excised. As you can see in the picture on your left, the patient has a scar above her right eyebrow. A repeat CT brain done 3 days later showed no intracranial bleed or any residual tumor. Postoperatively, she did develop hypopituitarism with some diabetes insipidus and hypothyroidism. There was also steroid-induced hyperglycemia, which she was treated with thyroxine, minirin, hydrocortisone, and insulin. She recovered and was reviewed in the maternal medicine clinic at 28, 31, 33, and 36 weeks. There was resolution of symptoms, the baby was growing well, and the HPE came back as consistent with a pituitary adenoma. However, she underwent an elective cesarean section for a deep term breech presentation at 37 weeks. She was post-delivery. She was had an implant inserted, and the MRI done 6 weeks later showed a residual pituitary tumor measuring 1 by 1.8 by 0.8 centimeters. So, moving forward, I would like to explain and give you a brief overview about the pituitary gland. The pituitary gland is located within the hypophyseal fossa of the sella turcica of the sphenoid bone. It's a very small and confined space within a bony structure. The pituitary gland has the anterior pituitary gland and a posterior pituitary gland. And as we all know, it's known as the adenohypophysis and neurohypophysis. So the pituitary gland usually in pregnancy is known to increase in its size about 136%, which is about 2 to 3 folds. And this is due to the hyperplasia of the lactotroph cells, which are located within the anterior pituitary gland. The height of the gland correlates with the gestational age, and the peak seen immediately postpartum, measuring up to 10 to 12 millimeters. And this returns to its normal size, volume, and shape within 6 months. How do you differentiate between a physiological versus a pathological enlargement? Physiological enlargement is usually diffuse, and the pathological enlargement, you will see an obvious tumor or growth causing an infundibular stalk deviation and the associated complications like pituitary apoplexy. The pituitary gland is also has a very rich blood supply, as you can see in the cartoon below, with the superior hypophyseal artery supplying the anterior pituitary gland, and the inferior pituitary gland, the posterior pituitary gland is supplied by the inferior hypophyseal arteries. Looking at the MRI sagittal image of the pituitary gland, as you can see, it has a very close relation with the optic chiasm superiorly to it, the hypothalamus, and is connected by the infundibulum. The coronal image here on the right shows the optic chiasm is flanked by the internal carotid artery, cavernous, and the cavernous sinus. Going back to the pituitary hormones, the anterior pituitary gland is known to synthesize 5 hormones and it has 5 cell lines within, which are the corticotrophs, which are responsible to secrete ACTH, somatotrophs for the growth hormone, lactotrophs for prolactin, gonadotrophs for FSH and LH, and your thyrotrophs to secrete thyroid-stimulating hormones. Whereas the posterior pituitary gland usually stores the vasopressin and the oxytocin, which is synthesized by the hypothalamus. So I would like to speak a bit about prolactinomas before moving on ahead regarding pituitary apoplexy. So pituitary tumors, 15% of it accounts for 15% of intracranial tumors. Half of them are functioning pituitary tumors. And if you can see this paper by Kimberly and Catherine Williamson, the annual incidence of pituitary tumors, prolactinoma accounts to about 10 cases per million compared to acromegaly and Cushing's, which are 4 and 2, and the non-functioning adenomas about 6. So what do you do when you see a woman in your pre-pregnancy clinic? Usually these women present in the reproductive age group with complaints of infertility, menstrual disturbance, or galacturia. So of course, a full and proper physical examination and visual field assessment should be done, complete hormonal workup, and an MDT involvement with the endocrinology and the neurosurgical team. The aim is to reduce the size of the pituitary macroadenoma to less than 1 centimeters by either medication, surgery, or radiotherapy. And of course, achieving a much lower and controlled prolactin levels before embarking on pregnancy. So before going further, macroadenoma, we need to know is a measurement of more than 10 millimeters, and microadenoma is less than 10 millimeters. So if you look over here, talking about likelihood of symptomatic enlargement of pituitary tumors, this is also by the same paper by Kimberly and Catherine Williamson. As you can see, if the woman has a microadenoma and has no prior therapy, the risk of a tumor enlarging during pregnancy is about 1.4% compared to a macroadenoma which is already treated, the risk is 3%. However, the more alarming and dangerous condition is when the macroadenoma has no prior therapy, means a tumor more than 10 millimeters, the risk of tumor enlargement is up to 26%. So moving forward, a brief overview on dopamine agonist. What is its role? So as you can see over here in the cartoon on your left, the maternal pituitary gland secretes prolactin, and this is further with the positive feedback from your placenta, your amniotic fluid, and your decidual prolactin. This will stimulate your estrogen, and estrogen in turn stimulates lactotroph hypoplasia, and this will cause increased prolactin secretion. So how to reduce the prolactin is by giving a dopamine agonist to reduce its secretion. So we have bromocriptine and carbogoline. Bromocriptine is a semi-synthetic derivative of ergoline. It's a D2 agonist. There's a starting dose of 1 milligram a night, and this can be gradually increased to about 5 milligrams every 6 hours. Yes, it reduces the level of prolactin, but it's a bit variable on the tumor size. It has more side effects compared to carbogoline. Carbogoline is more better tolerated and has lesser side effects. And with carbogoline, it's known to have almost 90% shrinkage in tumor size. So I'd like to bring attention to this paper by Mr. Molik, where there's a lot of concerns previously on the safety of bromocriptine and carbogoline during pregnancy. And in this paper, what we can see that bromocriptine carbogoline is compared to the general population, the risk of spontaneous miscarriages is about 9 to 7.5% compared to a normal general population of 10 to 15. Term deliveries are about 87 to 89%, similar to the general population. And babies with malformation, which is the most feared effect from a pregnant mother, it's similar, which is about 1.8 to 2% compared to 3% in your normal population. So this can be reassuring numbers which will, when you counsel the women regarding safety of these drugs to be commenced during pregnancy. So what is the algorithm for prolactinomas in pregnancy? As you can see, when the pregnancy is confirmed, you need to know whether it's a micro or a macroadenoma. Micro again less than 10 millimeters. As we know, like I previously mentioned, the risk of tumor enlargement is about 1.4%. So you can stop the dopamine agonist, and if it's a stable disease, you monitor her with visual field assessments every trimester. You can do a thyroid function and urinary free cortisol. Unless there's a symptomatic tumor enlargement, then you go down the other pathway. And of course, postpartum, a radiological and hormonal workup needs to be done. Compared to a macroadenoma, there is an option of stopping the dopamine agonist, but in certain three situations, you need to still continue the dopamine agonist. When there is a suprasellar extension of the tumor is close to the optic chiasm, and there was only a short period of treatment, which is the dopamine agonist prior conception. So in these situations, you will need to continue the dopamine agonist. So how do you monitor such women? Again, more frequently than the ones with microadenoma, with a visual field assessment every 4 to 6 weeks, and monitoring their thyroid function and urinary free cortisol every trimester. So when the woman does have a symptomatic tumor enlargement, or where there's abnormal visual field assessments, and she progresses and develops diabetes insipidus, this will need to make us move forward for further immediate investigation, which is an MRI to assess for tumor growth or any evidence of apoplexy. Of course, a full hormonal workup, which encompasses the anterior pituitary hormones. So you need to restart the dopamine agonist, and if there's no response within 24 to 48 hours, the next best option would be a surgical decompression using a transsphenoidal route. So in postpartum, a clinical and hormonal follow-up should be done with the endocrine team following pregnancy. So for women who are keen to breastfeed, because this becomes a most common concern for the pregnant mother and who wants to breastfeed, they may need to stop the dopamine agonist prior to delivery. And of course, risk versus benefit needs to be discussed. and the risk of possible tumor expansion and the risk of it causing an optic chiasm compression needs to be explained when you cease the medication. And if you do cease, it's warranted to do an MRI 4 to 6 weeks to assess the stability of the tumor. And if you can see regarding contraception by the FSRH, which was released in 2012, women with prolactinoma can use POP, and women can also use COCP with microprolactinoma, but at less than 30 micrograms. And of course, this needs to be in collaboration with the endocrinologist. So moving forward, I'll be talking on pituitary apoplexy. It is a neuroendocrinological emergency. So what happens? Again, estrogen stimulates the lactoferrin cells. It transforms it to prolactin-producing pregnancy cells. So this causes a rise in pressure within the gland, causes ischemia, thrombosis, and when it enlarges, there's an abrupt disruption of the pituitary tissue and the blood supply, and this can cause either hemorrhage or infarction into the gland. And most commonly, it occurs in a woman with an underlying pituitary tumor. It can also happen with women without pituitary tumor. Usually, this is due to the physiological enlargement, which usually happens in pregnancy. So the pituitary gland, which is so richly supplied with blood, suddenly is devoid of it. How would the patient present? They will have severe headache, 94%, visual disturbance in 61%, nausea in 33%. But if you look at this picture on the table on your right by Randev and Sibal, this was done in the non-pregnant population. Yes, headache is similar, 95%, the nausea, but visual field reduction is the third most common complaint. So diabetes insipidus, you may ask, it's happening in the posterior, is due to the posterior pituitary gland. This occurs when the bleeding is so much, and there can be resultant edema and inflammation of the gland, causing impeding your posterior pituitary gland and hence leading to diabetes insipidus. All the symptoms can start as early as 24 weeks till postpartum. How do you approach? Of course, history taking. The patient will complain of sudden severe headache, which is retroorbital in nature. They will have visual field reduction, impaired consciousness, and the associated pituitary dysfunction. Examination is full physical examination. You can do a neurological examination of your cranial nerves, especially your oculomotor nerve, and in ophthalmic examination, a simple bedside confrontation test can be done. Looking at the picture beside. Blood tests, you can do your electrolytes, your renal profile, coagulation profile, and of course your pituitary function, which is your cortisol, ACTH, IGF-1, growth hormone, thyroxine, TSH, and prolactin. Imaging is best. You may ask MRI versus CT. MRI, it confirms the hemorrhage within the gland and also its compression on the optic chiasm. That's one of the main advantages. It can detect up to 90% of cases of pituitary apoplexy and also other neurological emergencies. And it's important that if a woman presents a visual impairment, an MRI it will be the imaging modality of choice. Of course, certain MRI is not widely available in all settings, so if the CT scan is done, it will only show areas of hyperdensity within the cellular region, and it can only detect less than 30% for pituitary apoplexy. So if you do suspect still, you need to refer her to a tertiary center with the facility of an MRI. So what's the algorithm of management of pituitary apoplexy? If there's a clinical suspicion, it's important to maintain hemodynamic stability. You need to maintain the water and electrolyte balance, and you have to consider treating a high dose of IV hydrocortisone with an initial bolus and continuous infusion, taking the full biochemical and hormonal profile, and urgent MRI is indicated. You need to get the neurosurgeon and endocrinologist on board as soon as possible. And if symptoms worsens and there is deterioration, of course, the next course of action would be a surgical decompression. But if the patient has the symptoms and everything is still not worsening, a conservative approach can be taken. So if you can see by this paper by Aldensa, the acute pituitary apoplexy means it's a severe neurological deficit which evolves in 24 to 48 hours despite the initial treatment. This can be life-threatening emergency and requires an immediate surgical decompression. MPT is full maternal medicine, endocrinology, ophthalmology, and neurosurgeon. You can see the paper by Sophie in pituitary apoplexy. There is always an overlap between hormonal treatment, medical treatment, and surgery. So how does a woman recover post-pituitary apoplexy? 50% either have a partial or complete recovery. They can evolve to partial or complete hypopituitarism, and 80% of these patients will require some type of hormone replacement therapy, either growth hormone, gonadotrophins, ACTH, TSH, or vasopressin. And how about women's visual signs? Usually they show improvements, they're improving fast. However, if they have visual loss, recovery is less likely. And recurrence of apoplexy or tumor growth is seen in both patients who underwent surgery or a conservative approach. So it's important to have a long-term follow-up in these patients to detect potential recurrence. Moving next will be my second case presentation. So with that, this is Madam CMK, a 41-year-old gravida 3 she herself was told to be born via vaginal bridge delivery. She had a maternal short stature of 141 centimeters. Her first pregnancy, she delivered via cesarean section due to secondary arrest, with a birth weight of 3.7 kilograms. She has an underlying central hypothyroidism secondary to pituitary hypoplasia. She was diagnosed at the age of 13 when she was told to be shorter than her other siblings. There was a thyroid dysfunction and growth hormone deficit at that point. An MRI done showed an anterior pituitary hypoplasia with a depressed diaphragm and a prominent suprasellar cistern. She was on L-thyroxine pre-pregnancy and presented to us at 18 weeks. She was asymptomatic and normally scan was normal, and we had a combined care with the endocrinologist for optimization of the thyroid function levels. As you can see over here, her T4 was always ranging slightly lower, 7, 8, and then when thyroxine was started for her, it slowly, gradually increased. Her TSH always ranged between 5 to 6, then decreased to 4. During this pregnancy, she was planned for a cesarean section and bilateral tubic ligation as she was not keen for a vaginal delivery. It was uneventful and postpartum. She was followed up with an endocrine clinic and maintained with an L-thyroxine dose of 150 micrograms. On contrary to the first case, she has a much milder presentation. So what is central hypothyroidism? The hypothesis is of pituitary hypoplasia. It can be due to a perinatal hypoxia or anoxia. It can be due to a pituitary stroke transaction syndrome during a breech delivery, which is possible based on the case presented before this. Congenital hypoplasia of a portion of the axis, or it can be a genetic cause of the mutation in the GHRH receptor, which can cause to the anatomic pituitary anomalies. As you can see over here, this is the TRH thyrotropin axis during pregnancy. Hypothalamus secretes TRH, stimulates your pituitary gland to secrete TSH, which in turn stimulates the maternal thyroid to release free T3, T4, and then followed by the cross-reactivity with the HCG with TSH. The central hypothyroidism is actually a hypothyroid state which is caused by insufficient stimulation by the thyrotropin TSH from the pituitary gland in an otherwise absolutely normal thyroid gland. So secondary hypothyroidism is when it's pituitary in origin. Tertiary hypothyroidism is when it's hypothalamus in origin. And of course, primary hypothyroidism, you all know it's due to function in the thyroid gland itself. So how do you diagnose this condition? It's when you measure both the free thyroxine and the TSH. You'll usually have low to normal levels of serum TSH, and there'll be low levels of serum free T4. It can be either an isolated finding or again associated with other pituitary hormone deficiencies. Causes of acquired central hypothyroidism is as follows: pituitary adenomas, iatrogenic causes, injuries, etc. So how do you manage these women? So it's important pre-pregnancy is to increase the dose of the levothyroxine by at least 25 to 50% as possible. Ideally, once the pregnancy is confirmed by at least 4th week of gestation. The recommendation is to maintain your free T4 levels in the upper quartile of the trimester-specific range, as you can see in the graph on the right. As you can see in the first and second and third trimester, we want to follow in the upper quartile range. So this is in contrary when we're managing women with primary hypothyroidism, where we try to aim management based on your TSH levels. And lastly, I would like to talk very shortly about Sheehan Syndrome, and we all know it's usually due to postpartum hemorrhage. So based on this paper by Karaka, the diagnosis is by 6 criteria. It's when there's a typical obstetric history of severe postpartum hemorrhage, there's severe hypotension or shock with blood transfusion or fluid replacement necessary, the woman fails to have postpartum lactation, the woman fails to resume regular menses after delivery, there are varying degrees of anterior pituitary failure, there can be partial or pan-hypopituitarism, and when a CT scan or MRI is done, there is an empty cella. Statistically, pan-hypopituitarism is about in 55 to 86%, which is a pretty big number. Women, diabetes insipidus is rare, but the hormones which are affected, again, ACTH deficiency, hypotension, lethargy, hyperpigmentation, TSH deficiencies, prolactin deficiency, FSH and LH deficiency. But the most common deficiency that is seen in Sheehan's is growth hormone deficiency. The women who have abnormal body composition, reduced muscle strength, elevated lipids, and reduced bone marrow mineral density. How do you treat these women? It's basically to replace all those deficient hormones. So, well, to end my topic, I've only touched about half of pituitary disorders. There are other related pituitary disorders that are important for us to know. As you can see in the picture on the top left is a woman with acromegaly. Below there is a condition, as you can see, is Sheehan Syndrome. Here the typical purple abdominal stripe, and of course another very rare situation called lymphocytic hypophysitis. With that, I'd like to end with my take-home messages. It's important to have a high index of suspicion and rapid identification of pituitary apoplexy and its associated endocrine disturbances. Imaging is safe and is an essential part to aid diagnosis. Not all headaches are preeclampsia. Dopamine agonists may be considered in pregnancies for macroprolactinomas, and it can be safely used. MDT is the approach to reduce maternal and fetal morbidity and mortality. Confrontational test is a simple bedside test. With that, these are my references, and thank you very much.